Good morning. It's always a pleasure to be here in Kolkata. One, because I like Misty Doi. Two, because I see the academic feast here. So thank you very much. So without wasting time, I'll go ahead with the interpretation of cath data in pediatric patients. Among the greatest achievements in the cardiovascular medicine in the past century have been the advent and development and refinement of the invasive and diagnostic therapeutic modalities in the cardiac catheterization. And hence, Cournard called it as a key in the heart. And this is the book, The Comprehensive Approach to Congenital Heart Disease. This is the cardiac catheterization and imaging for the postgraduates. And this is how the teachers, the senior teachers like Shantanu Guha has to give it to the next generation so that we do better. The demise of diagnostic catheterization was predicted 3 decades ago with the introduction of echocardiography, magnetic resonance imaging, and computerized, that is the CT imaging. But however, on the contrary, today the catheterization is part and parcel because we are doing intervention. So the clinical history diagnosis is the foundation, and ECG, X-ray, angio, everything is like pillars, and interventions are the roof. And if you don't want the roof to collapse, you have to be very good at what you do. In the examination, they'll ask you what are the right heart catheters, and like I asked the previous speaker why the pigtail was not used, and they'll ask you how many holes are there and all those things. So you should remember these things and identify the catheters and learn them. Now, indications is very important. Already he has shown you how to analyze the oximetry. And here you can see that the PA pressure is almost 83, and then you can see that the PA pressure is very high. PVRI is 10, that is before. It is literally inoperable because anything above 7 you are not going to operate. But however, when you give oxygen, it has come down to 3.7. That means it is operable. So that means it's a reactive hypertension, and this is just 1 year, 3 months baby. So that is suitable for surgery. So the final diagnosis is cath oximetry study revealed systemic PA pressure and a high PVRI, and with oxygen significantly there was a reduction, and hence the patient is integrated approach. When you take the history, clinical examination, ECG, X-ray, everything, they said it is in favor of not operable. But however, I would like to think out of the box and see that that patient has to go for the PDA closure first, and then again do the cath and review it, and then probably it may become operable later on. So this is how you have to think, Don't say that inoperable in a small child. Now this is a 6 years presented with the history of dyspnea, exertion. P2 was loud, and then there was this is the saturation. So what do you think? The wedge pressure was not given and the PVRI is not given. This was done in 2010, and then they did the PDA ligation at that time. And after 10 years, the child was referred to me when she was almost 16 years, and at that time resting saturation was between 88 and 92. And 88, 92 means it is the light on the wall and you can't make the decision, and here your catheterization becomes very, very important. Now, would you like to leave her alone for the natural history of severe PAH? And then 15 years survival is only 77%. And we had a beautiful Madhubala, he died of Eisenmenger's with a large VST. So would you like to have another tragedy? Or would you like to close surgically with the flap surgery? And the mortality is almost 13 to 32%, very high. Now, would you like to do the device closure? There is no literature. But then if you have a sound scientific basis and if you analyze properly, and then you can do. Now look at the ECG, the tall R wave in V1, it is almost systemic, and the QR pattern is there. One may think that it is a suprasystemic PA pressure. And here you can see that there is a right to left shunt 0.6 liters initially, but once the oxygen is given, right to left shunt is almost gone. And the PVRI from 13.8, it has come to 7.7. 7 is a cutoff, now 0.7. Would you like to do the surgery, or would you like to intervention or not? Or leave her alone to go for the Eisenmengers? So I am always experimental person. So what I did was, apart from the drugs, I did try to do the device closure. Before that, to avoid the suicidal RV, I opened the PFO with the tie-shack balloon, so that in case there is a RV pressure goes up, there is a right to left shunt vent is there. That is the first, like taking the precautionary measure. And that is the angio. Large VST was there. And then I took the atrial septal device, so that the rims are adequate and that can close. No, it slipped off. 22 millimeter VST I took, it slipped off. So I got a 24 millimeter VST. Like how surgeon does the flap surgery, I made 2 holes in the device with the 7 dilator. So 7 French dilator is making into almost 14 millimeters, and with the 2 holes like a flap, then I did the device closure. And now you can look at the pressures, the aortic pressure, pulmonary pressure, and you can see that simultaneous RV, LV, where both are very systematic and very important. Unless you have both the pressures, you cannot release the device. So ultimately, successfully it was closed with the 24 millimeter vascular device. Of course, there is no literature, nobody has done, but then you have a intention to save the girl, and this is what successfully done. And now she's 25 years old, and on the echo her PA pressure has come down to 45. What would have been an Eisenmenger's without this thing, and that has been brought down. Now she's ready to get married and have the children. Otherwise, in Eisenmenger's, having the children is out of question. So this is how you have to think out of the box and try to do your best to the patient, and this can happen only when you have a very sound and good knowledge about the catheterization and the analysis of the basic. So this is a 14 years old child, breathlessness, exertion, and then the upper limb pressure is 140/90, generalized anasarca is there, JVP is red, saturation is low, cyanosis, just 48% saturation. So that means literally the child is dying. So this is the triology of Fallow. Triology of Fallow is the one where there is a pulmonary stenosis and there is a right to left shunt at the RA level. And look at the RA. Can you see the RA, how big it is? It's so huge. And this is how the RA is, and oligemic lung field. Once there is oligemic lung field, the patient is in failure, and then ejection systolic murmur, that is the severe pulmonary stenosis. Now, where is the catheter? Answer quickly. Take the mic and answer. Where is the catheter? Right heart catheter? Answer. Huh? Yeah. See, look at the right heart catheter. It has taken a turn like this and gone into the coronary sinus and into the LSVC. So this is not the pulmonary artery. So what happens is, whenever the RA is enlarged, this is how the catheter goes. So you have to be careful and use the other catheter. Now it is across with the 12x30 tie-shack balloon I have dilated. Can you identify these two? Anybody knows? This is Shakil Qureshi and this is Mike Tynan, a great friends of mine. And tie is Tynan, shack is Shakil. And that's how we have the tie-shack balloon. So now you have the legends there. And this is how the catheter is taken. So the pulmonary artery pressure is low, and then in the RVOT, and then the RV, and that is the aortic pressure. This is how the pullback tracing, the end hole catheter is taken. This is just 24 days baby, and first dilated with the 3.5x20 PTCA balloon, and then with the floppy guide wire, and then opened with the 6x20. You have to go graded. Otherwise, they go into the flash flooding and the pulmonary edema. So here you can see that the gradient came down from almost 130 to 126 to 43. And this is how this ejection fraction also improved in this patient. So literally this is life-saving. And this is more risky. This is the newborn baby with the pinpoint pulmonary stenosis. You can literally see that that is a pinpoint, and crossing itself is difficult, like threading the needle, and absolutely no flow in the lungs. Now how do you do it? Use the Sims catheter and then use the floppy guide wire so that you don't cause any arrhythmia, and straight away enter the PA. And first I dilated with 1.5 millimeter PTCA balloon, and then with the 2.5 PTCA, and then with the 6 millimeter. Why you have to go graded? Suddenly if there is a flooding, the child will go into pulmonary edema. So you are pushing the child more towards the death. So this is how you have to do that. Though it is risky, it is life-saving. And today this girl is a model, and such a beautiful girl she has become. And this is how literally you can save them. So this is the tetralogy. And what is important is this is infundibulous stenosis, that is the valvular stenosis, that is the supravalvular stenosis. Almost 25% of the tetralogy have at a different level RVOT obstruction. And this, since the child was very sick, we have done the stenting of the RVOT so that the surgery can be done later on. So otherwise I do the balloon dilatation, allow the pulmonary arteries to grow. This is the 3 years old child, 10 kgs, had a systole-diastolic murmur. What are the conditions where you get a systole-diastolic murmur? Can you answer? Where do you get the systole-diastolic murmur? In a cyanotic. Absolutely. Give her a big hand. When there is an absent pulmonary valve, the annular narrowing causes the stenosis, and absence of the pulmonary wall causes the severe pulmonary regurgitation. So here you can see that the pulsatile mediastinum is there, and that pulsatile mediastinum, when you do the angiogram, you can see that it is a dilated pulmonary artery in the tetralogy with the absent pulmonary valve. So absent pulmonary valve, when it is there, you can see that the post-stenotic dilatation is seen, which is not seen in the regular tetralogy where there is an infundibular stenosis. And this is how the absent pulmonary valve, you can see that there will be free PSPR, both will be there, and this is how aneurysmally dilated main pulmonary artery or branch pulmonary arteries are seen in a tetralogy. That's a rare subset of the tetralogy of Fallot. So this is a 3 years old patient, saturation 75, cyanosis, clubbing, and there is a continuous murmur. So any continuous murmur, you must identify what is the cause for that. And here you can see that what is the catheter? This is it's a pigtail catheter. But where is it? See, pigtail catheter from the aorta, it has to enter the LV. But where is it? RV. So what are the conditions where the left heart catheter goes into the RV? DORV. So whenever there is a DORV, instead of entering the LV, the catheter will enter the, give her a big hand. That's how you have to identify, that is the trabeculated one. And now this is the same pigtail catheter. The descending aorta angiogram is done. You are seeing the opacification of the pulmonary arteries. So what is the condition? What are the possibilities? So either there is a PDA or a BT shunt, one of the two. So how do you make out? There are one, collaterals may be causing the opacification, two, BT shunt may be there, or the PDA is stented and that's how it is opacified. So here this is the DORV, non-restrictive muscular VST, bidirectional shunt, and pulmonary stenosis also was there, and there is a functioning BT shunt. You can see that that is the functioning BT shunt. Okay, that vertical one is the functioning modified BT shunt. So in DORV you have 16 types depending on the VST committed and then whether the aorta is also committed. So here you can see that this is there in my textbook. From the LV, simultaneous opacification is there. Pulmonary artery and aorta are side by side. They are running parallel. Here there is aorta, the LV is committed to the aorta. So most of the dye is going into the aorta and also the pulmonary artery. And the other variety is, this is a doubly committed, and here you can see that the aorta and pulmonary artery as anteroposterior, making it as a narrow pedicle. So these are the 4 varieties of the great arteries, and the 4 varieties of the VST committed, either to the aorta, to the pulmonary artery, or both are not committed. That is the rare one. So depending on that, your management and the surgery depends. So this is the 9 months old baby, sucrus suck cycle, heart sounds were better heard on the right side. So what is the clue? That is the dextrocardia. Once the heart sounds are better heard on the right side, then you have to see the situs, whether it is a situs inversus or it is a situs solitus. So here you can see, what do you see? It's a pigtail catheter. It has gone into that empty space is the mitral valve, okay? What you see, the circumference inside is the mitral valve. So it is there. Now you can see that there is a VST as well as the PDA. Now anybody would have left it, but what I did was, first I closed the PDA with the device, and then the PA pressure came down, and once the PA pressure came down, and then the VST also was done. So simultaneously you can close the PDA as well as VST, close the distal one first and then come to the proximal, so that you can reassess the PA pressure. So what do you see here? Pigtail is in which ventricle? Huh? It is LV, but what has happened is there is a hypertrabeculation. So there is a non-compaction. Just because there is a hypertrabeculation, don't jump to the conclusion that is the RV. So this is the LV, but there is a non-compaction. And non-compaction with what you see? A VST. Dextrocardia, non-compaction with the VST, and it is so easy, you can just go through and cross the VST with the floppy guide wire, and over that you push the catheter and close with the device. Within 5 minutes you are done with the closure. So this is how the VST is closed, and this here you can see that the fundal gas is on that side. So it is a true dextrocardia, and the LV forms the apex. Whereas if it is an isolated dextrocardia, RV will be forming the apex. So here you can see that this is the 11 months baby with the bilateral Harrison sulcus and fixed S2. And what you see here? Dr. Santanu Guha showed you the saturations, and you answered the question, and when I'm showing the angio, you're not able to make out. Echo can make the diagnosis, but the cath can tell you. What is important is, so here the right heart catheter has gone into the RA and then to the horizontal vein, the vertical vein, and this is the supracardiac TAPVC. And whenever there is a supracardiac TAPVC, as he showed, all the chambers will have the same saturation, that is the hallmark. Echo itself can make out that there is a figure of 8. So whether it is an X-ray or echo or angio, the figure of 8 is a classical picture. But what is important is, with the echo you can make the diagnosis, but you cannot make out the saturations, and more than saturation, the pressures. So here what happens is, why it is important to go into the vertical vein and then pullback tracing has to be taken is, what is called as a hemodynamic vice will be there. That means the vertical vein is caught between the left pulmonary artery and the left bronchus, and as a result the compression can cause the obstruction to the vertical vein, and that can be made out only by the pullback tracings, and this is how it is very important for the surgeon to make out. Now what is this? Can anyone answer? Even the seniors can answer, no problem. Anyone? NIH catheter is in the LPA, and liver phase, you see that the pulmonary veins are draining, giving rise to the candy cane appearance. When do you get the candy cane appearance? Can anyone answer? This is the azygous system. So when there is a azygous system and the pulmonary veins are draining the common chamber into the azygous system, you get like that. So I have gone into the azygous system and taken the pressures and given the complete data to the surgeon to operate on that. So that is the cytosolitis TAPVC to azygous system, and that is the EST with the pH. So rare variants are surgical importance for posing the risk. You have to tell. Sometimes you can have the mixed TAPVCs, one draining into the coronary, other one into azygous. So all these details have to be given to the surgeons. Anyone can answer this? What do you see? Where is the catheter? Take the mic and answer. Anybody? Where is the catheter? Anyone? Including Geeta. Anybody can answer. Sir, Santanu sir, where is the catheter? It's a right heart catheter, right? From the RA, it has gone to? Huh? Yeah, the catheter has gone into LSVC, that's right. But when the dye is injected in the LSVC, where is it going? That's the important. I showed you the earlier. Huh? Huh? No, take the mic and answer, no?
Coronary sinus, then LA, then LV.
Yes. See, previously I showed you the catheter in the LSVC draining into coronary sinus. Here the LSVC is draining into the LA. So, what is it? What is the diagnosis? Can you see the appendage? That is the LA appendage. That is the LA. The whole dye is coming into the LA. So, he showed you the TAPVC. I am showing the TASVC. SVC draining into the, this is the systemic anomalous drainage. Okay. The cyanosis will be there, and that's how you are seeing the appendage. So, this is a very rare variant, but you must know where the dye is draining and what is the condition. So, this is the LSVC draining into LA and causing the cyanosis. This is a 6-month-old baby with the divided left atrium. Now, you can see that through the AST, I have put the catheter there, and you can see that the huge appendage of the LA, and the LA appendage is distal to the membrane, and my catheter is proximal, and that's how we know this is the divided. Earlier it was called as the quadriatetum sinistrum, and now Bob Anderson prefers to call it as a divided right atrium. That is the better terminology. So here you can see that there is a divided thing, and here you can see that the same LPA angiogram is done, and you can see that it is draining into the coronary sinus also, and this is the mixed where I see quadriatetum with the TAPVC, and one part of it is going supra and part of it is going the intracardiac. So here you can see that the same person, the angio is done. What do you see? Okay, I'll show you something better. So you have the mixed type, supracardiac, intracardiac, infradiaphragmatic, and the mixed. So all the 4 varieties I have shown you. Now what is this? Identify the catheter. This is normal. LPA injection shows the normal pulmonary veins draining into LA, LV. Now the same thing I'll do on the right side. What do you see now? Do you see anything? Anyone? Anyone? Yeah, you are pointing right, but what is it? There is a paracardiac shadow here. The pointer is not working. Okay. Okay. What is this? This pointer also, arrow also is not seen. Give me the pointer. Can anyone tell? Okay. Now I have used the Berman catheter, inflated the balloon without allowing the dye to come back, and now what do you see?
Scimitar sign.
Scimitar. That is a scimitar. Okay, so you have to use the Berman catheter to get a good angio, and that is the scimitar. And the scimitar always The MRI, they say better, but cath is no less. Literally, you can show the whole scimitar where it is draining. So that is the scimitar syndrome. So this is the AP window, and just making the diagnosis of AP window is not adequate. We have to know the PA pressure, and that patient had a 32 PVRI and post-oxygen 25. So it was already inoperable. So PDA AP window cannot be distinguished clinically, but we have to make out. But when it is a small one, you can see that literally you can close it with the device. I have closed this AP window with the PDA device and with the excellent result. So if it is a small one away from the coronary arteries, that can be closed with the device. So remember, in cardiology, single diagnosis is not enough. There can be multiple problems, and here the patient had coarctation with the RSOV. So always identify the distal one, tackle it first and then come back. So I have stented the coarctation, then come back to the RSOV and closed it with the PDA device. So this patient was all the time treated as rheumatic fever, came with the atrial fibrillation, pulmonary edema, was taken on the table for the balloon valvoplasty. And I told my professor, sir, this is the coarctation. He got very angry and agitated. If you can't puncture, come. I said, I can puncture, sir, but this is coarctation. He didn't believe. So echocardiographer will see only thing, and they had missed the coarctation, and the duty doctor had not recorded the blood pressure in the upper limb and the lower limb. So be humble, be Indian, touch the feet, you will never miss the diagnosis. So patient had a mitral stenosis as well as coarctation. I opened in the same sitting the coarctation, and afterwards the mitral stenosis balloon valvoplasty was done, and the patient is doing fine. This is a 23 years old, 23 days baby, and you can see that the ascending aorta 110 and the descending is 68, and pre and the post dilatation. This was a 40-day baby, and my assistant, she was shocked. She said, ma'am, I can't raise the cuff. Why? The BP was 220 by 110 in a 40-day neonate. And this is because they had not felt the pulse. They thought it is a failure, and inotropes were given to the child because they had missed the coarctation. So the coarctation is dilated. That's why I told you clinical acumen is very important. So this patient did not cry after birth, and cesarean section was done previous evening, and then the neonatologist sent the baby to me in the morning. Within 14 hours, we did the angiogram. This is a pinpoint aortic stenosis, literally pinpoint. There is nothing going, and then opened up with the 4 millimeter PTCA balloon, and the moment the blood gushed, the whole pressure came down, LV function improved, ejection fraction improved from 30 to almost 60, and today the child is almost 14 years, and it's so mischievous. And this is a masterpiece, and here you can see that there is a large PDA and also aortic stenosis. So here PDA ligation was done, and then I asked the assistant to put the pacing lead, and before that what he did was he just released the PDA, and then the moment the aortic balloon dilatation was done, as soon as the balloon dilatation is done, the PDA started dancing. Why does it happen? When you inflate the aortic balloon, aortic pressure comes down, PA pressure is more, so the PDA device is pushed into the aorta. So it started whirling. I got worried. I thought it is the PDA has embolized and it is dancing like to and fro, and immediately I took the guide wire thinking that it has embolized into the LPA, and the moment I put the guide wire, the patient retched. The device went back and sat so well. And this is called the height of the self-centering device, and it was perfectly all right. So hemodynamics are very important. Always keep a watch on the pressures, and this is the aortoventricular tunnel, aorto right atrial tunnel, aorto right ventricle RA tunnel, all I have closed. And this one was a googly because whatever I tried, it was not possible to cross and make an AV loop, and it was turning. So what I did was, if you can't eat this way, try the other way. So instead of making AV loop, I kept a stiff guide wire by the side and then put the device from the aortic end itself. So there is the end of the tunnel, there is light they say, but here there is the thing. And here this is the coronary AV fistula, and here I used it from the other end. It was so tough, and closed it with the ADO2. And in 2013, this is among the best publication. This was a topping the list. So friends, this is how we can do the thing. To conclude, cardiac catheterization still remains the final court for the definitive anatomic definitive diagnosis and also very complex lesions, and you must have the found knowledge. And this is how 25 years back Kurt Amplatz looked, and then just before that this is how he looked, and that is Mike Tynan, this is Mullins, and that is King, and these are the great people who have done great work. And once Bob Anderson said, we have laid the foundation, and now the young Indians, you have to build the castle. And I wish all the best for all of you so that you become great interventional cardiologists. Thank you very much for your kind and the patient hearing. Thank you.